start with our classic immune modulator, immunoglobulin replacement therapy. It's been our mainstay for treating patients with immune disorders for many years. But we've evolved since then, and we've evolved into understanding whether or not we need to replace or modulate the immune system. So let's start with things that we know we can replace with. For example, in ADA Gbhd, we're able to replace the ADA enzyme with pegylated ADA. It is available commercially, and many of us use pegylated ADA to bridge to transplant. We also care for patients who've been on pegylated ADA for many years to prolong transplant for a variety of reasons. The second is the treatment of hereditary angioedema. So this is the pathway that we're all familiar with. And I'll point you here to one of the molecules that regulates our coagulation system, which is C1 esterase inhibitor. When C1 esterase inhibitor is missing or non-functional, it drives primary hereditary angioedema. And now we're able to replace this with recombinant C1 esterase. C1 esterase concentrates come in IV and now in subcutaneous form are available for prophylaxis as well as in emergency rooms across the country. And it was a breakthrough once we were able to provide this for our patients. We can also provide help downstream of the cause and provide areas where we can block the pathway which leads to angioedema, like bradykinin receptor antagonist icatibant or plasma kallikrein inhibitor ecallantide. These are effective where C1 esterase is not as effective or not available. We can also treat the downstream inflammatory effect. So when we know a defect causes a hyperimmune response, we can damp down that hyperimmune response by targeting with precision molecules. So for example, in leukocyte adhesion deficiency, where the either the alpha or the beta subunit of the integrin is missing, we can understand that there is an immense amount of inflammation. These patients develop cellulitis. They have mucosal inflammation that's difficult to control. Well, the NIH and Steve Holland's group did some elegant work with their dental colleagues to realize that downstream inflammatory molecules such as IL-12 and IL-23 were activated and elevated in these patients. And by blocking it with ustekinumab, or better known as Stelara, they were able to treat the patient's inflammation successfully. So, for example, in the paper published in 2017, you'll see that this patient's gingival disease resolved and this patient's terrible sacral wound resolved with ustekinumab treatment. We've come a long way since this initial meeting where Dr. Shearer and David taught us so much about the immune system and how treatments affect the immune system and patient outcomes. We've witnessed a memorable scientific revolution in our field over the last 10 to 20 years, and technological innovation is providing some exciting possibilities for us to treat these severe diseases with small molecule inhibitors, antibody therapies, RNAs, and gene therapy. And it's offering us the ability to treat the non-infectious manifestations of primary immune disorders, which is typically some of our more difficult manifestations to treat: severe refractory neuropathy, interstitial lung disease, autoimmunity, lymphoproliferation, severe allergy, endocrinopathy. But with some of the tools that we're going to talk about and understanding the underlying genetic mechanism, precision therapy offers our patient a good quality of life. One of the things that we struggle with is the genotypic-phenotypic overlap in some of our disorders, which is important to understand the underlying genetic defect because the phenotype may overlap, but the precision therapy may be different depending on the genotype. And this is the case in autoimmune cytopenias, where The autoimmune thrombocytopenia appears clinically, diagnosed clinically, but depending on what the underlying mechanism is and what compartment in the immune system the genetic defect arises, actually dictates therapy. So understanding that can be key. So why does it matter? Well, it applies to the spectrum of the natural history of patients. So understanding what the natural history of defects helps the next generation of patients. Mainly new discovered inborn errors of immunity share pathognomonic features with other inborn errors of immunity. And like I said, as the previous example, for autoimmune cytopenias, we treat them differently. So understanding the underlying genetic diagnosis is important. Atypical presentation of known diseases is really key in understanding whether the presentation in your patient is typical or atypical. And even though it's atypical, don't stick to the definition, because you might be able to investigate that your patient is just a milder form of the disease just because they didn't present at the age at which the textbook says it should have presented. We can advocate for precision therapy and immunomodulation, knowing the genetic defect and implications for undiagnosed family members is so important for genetic counseling and pre-implantation genetics. So it affects prognosis and treatment. And I know that this is being talked about in another section, but I thought it was important to bring up because it has huge implications on immunomodulation. And here's a perfect example. So I took APDS, which is the syndrome caused by Pi3 kinase mutation, to show that how patients with ADPS typically present and the distinct overlap of some of these important clinical features in other diseases of the immune system, for which therapy would be vastly different. So let's talk about Pi3 kinase signaling. It's a predominant signaling pathway for T cell activation. It's important for T cell differentiation and T cell function. It's also important for B cell differentiation and B cell function. And so what we realized was when Pi3 kinase defects were first described in 2014, what about treatment? How are we going to immunomodulate these patients? They couldn't stay on steroids forever. Steroids left them susceptible to severe infections. These patients already have an EBV susceptibility, a CD8 defect, an NK cell defect. So in looking at the Pi3 kinase pathway, it was important to understand that we already had a well-known, well-studied, effective modulator of something downstream of Pi3 kinase. And so patients were started on rapamycin. And the first initial reports suggest that there was significant benefit to the intense lymphoproliferation caused by this disorder. It had less effect on other things like gastrointestinal disease, some of the cytopenias, some of the interstitial lung disease, but it really did have an effect on lymphadenopathy and hepatosplenomegaly. So then, rightfully so, a clinical trial was developed by the group at the NIH, led by Kennedy Rao, for leniolisib, which is a small molecule inhibitor against the P1 delta of Pi3 kinase. And so when Dr. Rao looked at how his cohort was doing intermittently during the trial, he found that there was a reduction in the frequency of elevated transitional B cells. So if you notice from my chart before, a very prominent feature of APDS. Normalization of naive B cell frequencies, which meant that the B cell differentiation defect was normalizing. CD27-38 plasmablasts were also drastically reduced in a majority of patients, and PD1 CD4 positive cells were also reduced. Now, PD1 positive CD4 positive cells were reflected either chronic or activated and exhausted T cells or increased circulating T follicular helper cells, which we see in lymphoproliferation and autoimmune disease, and these were decreased, as well as markers of T cell senescence, normalization of IgM, and a discontinuation of IgG replacement, which really did solidify the normalization of the B cell differentiation effect. Lymphoproliferation and cytopenias also improved. So leniolisib actually had a larger and more broad effect on resolving some of the clinical manifestations than rapamycin did. There are side effects in terms of weight gain and increased lipids, but the side effects are not nearly as weighted as the benefits thus far. The clinical trial is still ongoing, and we await the final results. One of the other disorders that has a targeted molecule is the disorder of T cell activation. So T cells are activated by engaging co-stimulatory molecules, and they are deactivated by engaging inhibitory molecules like CTLA-4. So T cells are activated when CTLA-4 is not engaged by the antigen-presenting cell, and then when CTLA-4 sees its ligand, CD80, CD86, it shuts off T cell activation. This is important because CTLA-4 haploinsufficiency causes a dysfunctional or deficient CTLA-4 molecule. In addition, LRBA deficiency also causes a similar clinical phenotype because LRBA is essential in trafficking CTLA-4 to the surface. So when that mechanism is broken, it is as if CTLA-4 doesn't work. So CTLA-4 Ig fusion protein actually partially rescues the phenotype of CTLA-4 haploinsufficiency and LRBA deficiency. And that is abatacept and belatacept act as a surrogate for the missing or dysfunctional CTLA-4 molecule. Hot off the press this month, that's why it says journal preproof online, is an international cohort by Dr. Grimbacher's group in Freiburg, where he looked at just treatment of CTLA-4 haploinsufficiency. And what he found was abatacept was used when there was severe end organ damage. So like granulomatous lymphocytic infiltrative lung disease or neurologic involvement or gastrointestinal involvement. It appears that abatacept is very well tolerated and helps with the resolution of the disorder of the lung and the GI tract, but it wasn't employed for lymphoproliferation, cytopenias, and the skin involvement. So it's not clear as to whether or not it works for those organs or it just wasn't employed because other therapies were working just as well. I wanted to tell you about a case where broad immune suppression and immune dysregulation were so severe. And this poor child had to undergo a lot of intense immunomodulation before we were able to sort through what the underlying mechanism was. So she had been treated for her severe interstitial lung disease, her TPN-dependent enteropathy, and her refractory autoimmune cytopenias with methotrexate, 6-MP, solumedrol, Campath, Cytoxan, and then repeated Campath, Cytoxan, 6-MP, and solumedrol. And as a result, she had multiple disseminated infections and liver toxicity. So we did whole exome sequencing and we found a mutation in the STAT3 gene. And we didn't believe it at first because here you'll see that the paradigm for STAT3 was that mutations in STAT3 caused the loss of function. And it was the autosomal dominant form of hyper IgE syndrome with low Th17. And these patients had a susceptibility to mucocutaneous candidiasis, pneumonia, dermatitis, and connective tissue abnormalities. But our patient really had lymphoproliferation and interstitial disease and didn't really fit the phenotype. And through a series of collaborations, we found that there are mutations in STAT3 that confer gain of function signaling. And that is exactly what our patient had. So we've collected an international experience of 170 patients with STAT3 gain of function disease. And it turns out that the majority of these patients had very similar manifestations to our index case, lymphoproliferation autoimmune cytopenias, growth delay, severe neuropathy, and pulmonary disease. Another STAT disorder where the phenotype has evolved over time is STAT1 gain-of-function disorder, and how it was originally described as a disorder of chronic mucocutaneous candidiasis. But upon further investigation and time, learning how these patients present, we see that it is a heterogeneous disorder caused by autoimmunity and significant infection susceptibility. But we have small molecule inhibitors that inhibit the JAK-STAT pathway. There are 4 JAK-STAT inhibitors that are FDA approved at this time. And they inhibit specific molecules causing gain-of-function disease. So we collected a few years ago the international experience of treating STAT1 gain-of-function and STAT3 gain-of-function with JAK inhibitors. For STAT1 gain-of-function, we collected 11 patients, 6 of which had neuropathy, 6 of which had autoimmune cytopenias, and all of which were controlled with the JAK inhibitor. The chronic mucocutaneous was actually also better controlled on JAK inhibition. And 10 of the 11 patients survived with resolution of some of their disease manifestations. The one patient that died was started on a JAK inhibitor after they were infected with disseminated coccidiomycosis. So it's not clear as to whether or not the JAK inhibitor did not have an effect because she already had disseminated disease, or if the JAK inhibitor made the disease worse. For STAT3 gain-of-function, 6 patients have treated and 4 survived. 2 had resolution of their neuropathy, 3 had resolution of cytopenias, 3 had resolution of autoimmune hepatitis, and 1 had resolution of autoimmune-driven hepatic venous stenosis from the inflammatory vasculitis in the liver. 1 had marked improvement of her respiratory status, and 1 had resolution of HLH. 1 of the patients died on therapy. However, the other patient that died had very good control of his disease. He died of post-transplant complications. Our patient that I highlighted is actually off oxygen, off TPN, and has barely been admitted to the hospital in the last 6 years. So we were really excited to be able to use this off-label for the STAT gain-of-function disorders. But JAK inhibitors are also being more broadly used in other inborn errors of immunity that cause immune dysregulation, such as the interferonopathies like SAVI, CANDLE, POMP, and acardioUTI have very nice control of the immune dysregulation with JAK inhibition, baricitinib, and ruxolitinib, as well as tofacitinib. In addition, there are clinical trials for hemophagocytic lymphohistiocytosis, or HLH, and macrophage activation syndrome. Cytokine storm and macrophage activation, such as seen with CAR T-cell therapy, is also being treated with small molecule inhibitors and monoclonal antibodies. Targeted are IL-1 inhibition, IL-6 inhibition, TNF-alpha inhibition, and IL-18 binding protein, which are in clinical trials in the US. Refractory cases can also be treated with ATG and tacrolimus. But with the advent of IL-1 inhibition, IL-6 inhibition, and TNF-alpha inhibition, as well as IL-18 binding protein in the works, they are much better and safer options than ATG or tacrolimus. And moving through, speaking of IL-1 and IL-18, the inflammasomopathies now have an array of options in the IL-1 inhibition realm, as well as IL-6, and then IL-18 binding protein. So many of the disorders that I have discussed and the immunomodulators that I have discussed, you can find in this article that Dr. Lighting and I presented a few years ago. But really, the reason for me putting up this table is to show you how broad our immunomodulation choices are expanding and how understanding the underlying mechanism of the disease can really precisely target therapy and improve the patient's quality of life. So my final thoughts are, a significant number of immune disorders present with immune-mediated pathology as major features of infection. Specific genetic disorders are teaching us about the basic mechanisms so we can actually better target therapy. If you know the cellular mechanism or the genetics, you can personalize your patient's therapy. It's incredibly important in this era, and it is a team sport. We need all of our colleagues and all of our staff members and the patients to create a thoughtful team to bring the precision therapy to fruition. Innovation, using mechanism to employ new therapies for safe and innovative immune modulation and cure, is key for our specialty to advance in the future. I'm so thankful to be here. I want to highlight that I give this talk in memory of Dr. Shearer, who is a staunch advocate of the Immune Deficiency Foundation and a steadfast supporter and participant in the Clinical Immunology Society. I want to thank the patient and families. Without them, we don't have this kind of purpose to make their lives better. And we appreciate their partnership, all my funding mechanisms, and all of my colleagues out there doing this work. Thank you so much.
Okay, thank you very much, Dr. Forbes-Satter. So if anyone has any questions, you can enter them in the chat. And we'll just see if anything comes in. I think there was maybe a setting that had to be fixed. So hopefully everyone can enter things in the chat. So, okay, we have our first question. Do you think of JAK inhibitors as a prolonged therapy in STAT1, STAT3 gain of function, or is it more of a bridge to transplant? What is the longest duration of time you've had a patient on Rux?
So I think, thank you, Daniel, for opening up the questions and being the first one. It's really weird watching yourself on video and listening to your own voice. So that was an interesting experience. So I think of JAK inhibitors as both. And the reason that I say that is because I do think the more we learn about the disease and the earlier that we transplant, the earlier that we learn about the disease and the fact that we're diagnosing these patients earlier before their end organ disease manifestations progress, I do think that if transplant is an option, it should be highly considered. The frustrating part about it is that we don't have really standardized regimens for transplant, and you really have to be at a center that has experience in transplanting disorders of immune dysregulation. And so in that regard, I see it as prolonged therapy and as a bridge to transplant. And then unfortunately, some patients don't have good matches for transplant. And I think that we're learning in immune dysregulation disorders that that the donor matters, and we're not quite sure yet how we feel about haplo donors and things like that in some immune dysregulation disorders. So what I would say is it's both for those reasons. The longest patient I've had on ruxolitinib is the index patient for the STAT3 gain of function story that I highlighted, and she's been on ruxolitinib for almost 10 years. I mean, not 10 years, 7 years. She's been on tocilizumab for 8 years. She's been in my care for almost 10 years. So, but I think that we worry about her bone marrow, and we worry about the side effects of prolonged ruxolitinib therapy. And I will tell you that I learned this year that she became lymphopenic for reasons we couldn't explain, more lymphopenic than she had before. And so we decreased the dose of ruxolitinib, and about 6 months later, she developed just a common cold and then had a terrible inflammatory flare. And we admitted her to the hospital, and we did everything, head to toe imaging, bone marrow biopsy, bronch, endoscopy, because we just really couldn't. She had been well for so long, and it really made us nervous. And the end of the day, it was that we had decreased her ruxolitinib too much, and that just a small trigger of a cold caused an inflammatory flare of just the underlying disorder. And by putting her back on her high dose of ruxolitinib, it resolved. So I think it just taught us that we just have to monitor them closely. And she unfortunately does not have a good match in the bone marrow registry. So we just follow her pretty closely and do the best we can. But I think that she's such an extreme story because before we started JAK inhibition, she was living in the ICU on BiPAP. And she had been in the ICU for almost a year before we started it. And so we don't know. Cross your fingers. We submitted a grant to the NIH to do a basket clinical trial with JAK inhibitors for STAT1 and STAT3 gain-of-function disease. And we should hear in the next few weeks whether or not we're funded. And if that's the case, we're going to run the trial through the PIDTC and hopefully be able to answer some of these questions about long-term toxicity and efficacy, dose regimens, how do you dose, how do you follow biomarkers, all of that kind of stuff. So we're hoping that this will help us answer these questions a little bit better.
Thanks, that'll be exciting.
Yeah.
Okay, if anyone has any other questions, can enter them in the chat. I wish I knew. Okay.
Either it was very clear or I just overwhelmed everybody. So, but thank you so much. This is always a really, really enjoyable conference, and it's always very nice and to be invited. So I really appreciate everybody attending and listening to what I had to say.
Thank you so much. Great. We'll have our next presentation from Dr. Daniel Dulick. Just give me 1 second.
Good afternoon, everyone. My name is Dan Dulick. I am a pediatric infectious disease physician at Vanderbilt University Medical Center in Nashville, Tennessee. I'm very excited and thankful to be able to talk to you today at the Immunodeficiency Foundation National Meeting. My topic for today is antimicrobial prophylaxis in primary immune deficiency disorders, a comprehensive approach. Let's get started. Now, this is a big topic, and there's no way I'll cover all of it in the 20 to 30 minutes that we have allotted to us, but I am going to outline my framework and my big picture overview for how I approach these kinds of questions. So antimicrobial prophylaxis in primary immune deficiency disorders is very common. This figure on the right shows a survey response from a cohort of immunologists in the US. And it shows the percent of respondents using antimicrobial prophylaxis for certain disorders. And you can see that ranging from agamma-globulinemia to XLP, antimicrobial prophylaxis is used in anywhere between 50 to 90 or almost 100% of patients or practices. However, despite this common use, evidence is limited, and that's not to say that antimicrobial prophylaxis doesn't work. It's more just to say that specific studies in the patients with immune deficiencies are not commonly done. And so evidence is frequently abstracted from other clinical scenarios. And importantly, there are regional and sort of worldwide discrepancies in use. So the approach to prophylaxis in the US is different a little bit from that in Europe, and so on. Importantly, also, antimicrobial prophylaxis and in general the diagnosis and management of immune deficiency diseases is becoming increasingly complicated because there is an increasing number of immune deficiency disorders and immune dysregulatory disorders diagnosed. So this is data that you are all well familiar with from the International Union of Immunologic Societies, showing that the number of genetic defects described and reported has markedly increased over the last, 5 to 10 years even, but even longer. There has been an increase in the numbers. So So many more different kinds of diagnoses being made, many more new diagnoses being made for which evidence is incomplete. And so there is, as always, much to learn. So the sort of big picture for prophylaxis, the benefits, the potential benefits of prophylaxis, I think, are very logical and concrete. It's easy to picture that patients with prophylaxis have fewer infections, hospitalizations, and clinic visits, although these things are a little hard to quantify in randomized trials. The potential risks of prophylaxis are remote and hard to monitor, so clearly not all of your patients get antimicrobial resistance. And even more challenging, understanding what the impact of the altered microbiome from antimicrobial exposure is difficult. So we'll talk a little bit more about the lack of evidence there later on and cover that in later slides. So the objectives for this talk, I'll review a comprehensive approach to antimicrobial prophylaxis in patients with primary immune deficiency, and we'll review a couple recent studies for prophylaxis approaches in patients with primary immune deficiency. So I've tried to distill down my big picture approach to thinking about prophylaxis in patients with immune deficiency and immune dysregulation. And we'll review that a little bit here, and then we'll go into an illustrative case later on. So we start, as always, with the category of immune deficiency. So what are the defined genetics that genetic diagnoses or diagnosis that a specific patient has? And if they don't, what's the sort of syndromic category of immune deficiency that they have? Is it T cell, B cell, neutrophil, complement, etc.? Then we always review comorbidities. So is there bronchiectasis present? Are there any allergies or intolerances? And is there any end organ dysfunction that might impair or alter how prophylactic medicines are metabolized? As always, you review the specific infection history for a patient. What have they had previously? What have they had recently? What are the infections that they battle with most frequently? And then increasingly, we have to, well, as always, but increasingly we have to figure out, is there an immune dysregulation going on that might, say, for example, impair their mucosal barrier function? So is there colitis that might make them more likely to translocate bacteria into the bloodstream? And then from that, is there any iatrogenic immune suppression that's being administered to control that immune dysregulation? And how might that impact the prophylaxis strategy? And from that, you get a sense of the infection risks of a specific patient. What are the specific infections they are likely to deal with? What are the ones they have dealt with? And what's the prophylaxis strategy that you want to move forward with or you think is necessary? Now, I do add a few things that I call kind of modifiers to that. So that can impact the prophylaxis regimen that you choose for your patients. And those are three shown here, and we'll go into those in greater detail in later slides. So is there a definitive treatment option or options for your patient with immune deficiency? Is there a genotype-phenotype correlation? So if that's present, how does that modify the kinds of infections your patient's at risk for? And then what are the potential adverse effects for the antimicrobials that you're choosing? So to discuss this more in more detail and to give an example, we'll go through an illustrative case. So this is a 13-year-old boy with Nemo Deficiency who presents to your immunology clinic to establish care. He presented with spontaneous Staph aureus bacteremia at 6 months of age that was successfully treated, and he was subsequently referred to immunology for evaluation. In the course of that evaluation, he aged and he became 10 months of age, and his teeth started to erupt, and his pediatrician noted conical teeth. Therefore, targeted Pi3 Kinase gamma sequencing was sent, and that showed a pathogenic mutation, missense mutation in the zinc finger domain. So as a young child, his infection history was generally mild. He did well with occasional respiratory viral infections and no invasive infections apart from his Staph aureus bacteremia. Previously, he was on subcutaneous immunoglobulin replacement and prophylactic antibiotics. For our purposes, we won't really go into what he had before. He was having breakthrough infections, and then the family had to move and had to reestablish care with immunology. There were some gaps in care, a little bit of loss to follow-up. And they, in the course of that, stopped his prophylaxis 6 months ago. So he subsequently had 3 pneumonia episodes, one of which had strep pneumobacteremia that was azithromycin resistant. One time or shortly afterwards, he had a chest CT showing some developing right lower lobe bronchiectasis. And he had a Staph aureus soft tissue abscess as well in his right thigh that was methicillin resistant and also of note Bactrim resistant. So he's had occasional HSV oral outbreaks, none of which have been terribly severe. These have been about 1 to 2 times per year. And family is coming to you both to establish care and to revisit all the prophylaxis options. They want to know what the evidence is, and they want to know what the best course is for their child. So Nemo deficiency, I'm sure you all know well, is NF-kappa B essential modifier deficiency. Ever since the early 2000s, a link between ectodermal dysplasia with immune deficiency and mutations in the I-kappa B kinase gamma subunit have been well defined. And in the years since then, Nemo deficiency has been associated with a wide variety of immunologic and infectious phenotypes. So hyper-IgM, NK deficiencies, specific antibody deficiencies, and Mendelian susceptibility to mycobacterial disease. Now, I bring this up. I use Nemo in this setting, not so much as that this is a novel or a new diagnosis or even a new mutation, but more that it's just a really good model for reviewing all the considerations that go into antibiotic prophylaxis. You get to talk about a lot of the pieces of the puzzle with Nemo, and there are a lot of infections that these patients are predisposed to, so it gives us a chance to talk about a lot of angles on this. So getting back to our big picture overview approach. With this patient, his immunodeficiency category is clearly a combined immune deficiency with susceptibility to mycobacterial disease. He has some comorbidities. He has some early bronchiectasis, though he doesn't have any defined allergies or intolerances. Thankfully, he does not have any evidence of colitis or GI disorder with his Nemo. He does have a history of Staph aureus, as we talked about a second ago, as well as recurrent pneumonia. And he does not appear to have any immune dysregulation at this point. So based on his history, preliminary prophylaxis regimen might look like this. So he's predisposed to these organisms and has the bronchiectasis complication. So you could come up with a regimen based on those findings and his resistance patterns here with Bactrim, Clinda, Mox, azithromycin, cyclovir. So is this our prophylaxis regimen? Maybe, but hopefully not. It's a lot of antibiotics. There'll be a high pill burden there and could be challenging to administer. Clearly, if he needs all these things, then he should receive them. But I think there's a little modification that we can do. So then getting into our more targeted approach, looking at each of the pieces of each of the modifiers that I mentioned before, genotype-phenotype correlation, definitive treatment options, any evidence from clinical trials or clinical studies, and then what are potential adverse effects that he might encounter. And then we'll come back to our prophylaxis regimen. So for Nemo, thankfully, and it's one of the reasons I chose it for this case, there is some degree of genotype-phenotype correlation that's defined with Nemo deficiency. So 2 examples of that are here with mycobacterial susceptibility on top and then CD40 signaling / hyper-IgM phenotype on the bottom. This information comes from a paper from Jordan Orange's group from a while ago now, about 13 years ago, but I think it's still informative for thinking about prophylaxis in these patients. Clearly, genotype infectious phenotype correlation isn't always present and likely isn't present in many immune deficiencies, but when it is, it can be very useful. So as you can see in this graph, in this figure with the Nemo gene laid out in front of us, you have a variety of reported mutations shown here. And then you can see that some, but not all of these mutations are associated with a strong mycobacterial susceptibility. So the hatched lines show mutations, circle areas with mutations where there has not been reported mycobacterial susceptibility. And the purple colored in areas show mutations where there has been mycobacterial susceptibility reported. In the bottom, similarly, you can see with sort of the hyper IgM phenotype and the and impaired CD40 signaling, you can see mutations that are associated with those, and then some that are not associated with those. So in this paper, a very useful table was created from this data showing the mutations on the top line here, and then on the vertical axis in the rows, the different phenotypes ranging from ectodermal dysplasia to the different kinds of immunophenotypes that could be present. So for our purposes, with this specific patient, you can see that clearly ectodermal dysplasia is associated with his mutation. Viral infections don't seem to be very common. Hypogam is frequently reported, and then the hyper IgM phenotype is also reported as well. However, mycobacterial infection frequency is a little bit lower than you might see with other mutations. Now, this is useful, should be taken with a grain of salt, because you can see here that the numbers of patients contributing to each of these categories are a little bit low, and so only one of the 3 patients had mycobacterial infection, but still that could be a function of the low numbers of patients reported. Still, there is some utility in thinking about this in terms of what prophylaxis to use, and in certain other immune deficiencies, it may be more or less useful to think about the genotype-phenotype correlation. Another way of thinking about this is something that I've somewhat jokingly called the phenotype-phenotype correlation. So is there a correlation between the immunophenotype and the infectious phenotype? So what does the data from your specific patient tell you about their immune function and how that might play into their infectious phenotype? So for Nemo, there is some evidence that lab studies showing T cell impairment predict a severe clinical course. This is in a small cohort, and this group showed that skewing of T cells towards naivete, so lack of memory T cell differentiation, was associated with significant infections. In these more severe patients, they also showed impaired T cell mitogen proliferation. And so there is some honing of infection risk that can be done using functional assays, although, again, this has to be taken within the context of the bigger picture. The next modifier that I like to talk about is what definitive treatment options are there for your patients. So is there definitive therapy that can be used for the disorder that your patient has? Is stem cell transplant an option? Is gene therapy an option? And by extension, if there is therapy, or if there is not, how long will the prophylaxis be administered? So you can envision that if your patient is moving towards stem cell transplant, is just getting over a severe infection, you're going to go all in on prophylaxis to try and to successfully get them to transplant without a severe infection or without any sort of delay. And so you may tolerate a more aggressive prophylaxis regimen in that setting with more polypharmacy there than you might in another setting, because you're really just trying to get the patient through transplant. Versus if you have a patient for whom transplant isn't a great option, or isn't a viable option, prophylaxis may be a longer term play, and so you may not want to do as aggressive of a regimen. You may be stuck with limiting the number of antimicrobials that you can use for tolerance purposes. So just by way of example, there's data on for Nemo in an international cohort of almost 30 patients with Nemo deficiency, showing that stem cell transplantation is associated with about a 75% survival. So the question really is sort of, for your specific patient and your specific scenario, is there a therapy that you'd be aiming for to get the patient to? With Nemo, this isn't, stem cell transplantation, as you know, isn't always used, and it doesn't cure colitis if that's present. So there are a lot of challenges in thinking about that with Nemo. And then we come to what evidence is out there. So there are any clinical trials or cohort studies that can shed light on prophylaxis strategies for primary immunodeficiency patients. And we'll step a little bit away from our illustrative case here to to talk about what evidence is out there. So for antibody deficiency and chronic lung disease, chronic lung injury is a common complication of antibody deficiency disorders despite immunoglobulin replacement. Bronchiectasis occurs fairly frequently in antibody deficiency patients, ranging from 23 to 50% in different studies. And interventions, including antibiotic prophylaxis, could decrease infection frequency and could, excuse me, and could decrease pulmonary exacerbations. So exothermizing prophylaxis is used in the setting of COPD, of cystic fibrosis, of non-cystic fibrosis bronchiectasis, and has shown some benefit in reducing respiratory exacerbations. But until recently, there wasn't much evidence on this in primary immune deficiency disorders. However, 2 recent studies have shown, have looked at antibiotic prophylaxis in the context of antibody deficiency, and we'll review those now to keep us all up to date on the literature. So azithromycin prophylaxis in patients with primary antibody deficiencies was studied in a randomized controlled trial looking at azithromycin versus placebo in antibody deficiency patients with infection-related pulmonary diseases, you can see here. This was a double-blind randomized controlled trial with enrollment over 3 years. It was published in the Journal of Allergy and Clinical Immunology in 2019. And patients were followed pretty closely, or very closely, with baseline samples and studies, as well as monthly check-ins, quarterly pulmonary function tests, and then an end of study analysis as well. And what this cohort showed was that there was a decrease in the exacerbation incidence rate for patients who received azithromycin compared to those who received placebo. And you can see that in the per patient year numbers here, as well as in the hazard ratio. So the hazard ratio for respiratory exacerbation was 0.5 in the azithromycin group compared to the placebo group. And the number needed to treat, number needed to prevent one respiratory exacerbation was 7 in the azithromycin group. And you can see the Kaplan-Meier curve here, showing that over time there was a decrease in the frequency of exacerbations with the azithromycin use. Interestingly, there was no apparent impact on antimicrobial resistance in this. So azithromycin groups and placebo groups had similar frequent susceptible and non-susceptible isolates. There was no impact on percent predicted FEV1 over time, so that calls into question whether or not azithromycin prophylaxis would impact long-term pulmonary outcomes, even though the study showed that it did impact short-term respiratory exacerbations. And I will point out one cohort study from Dr. Cunningham-Rundles that showed that over a long period of time, it did not seem like bronchiectasis was an independent predictor of mortality in CVID. And so maybe this just calls into question some of the endpoints with the study and what the long-term benefit of azithromycin might be. A second study that doesn't play into our case as much, but is relevant given that it is a robustly performed study that was recently published in the Journal of Clinical Immunology. So in this study, the authors performed a randomized crossover trial comparing Bactrim prophylaxis with IVIG in patients with either Ig subclass deficiency or specific antibody deficiency. It was primarily in adults, and they showed there was no efficacy difference for infection prevention between IVIG and Bactrim in this cohort. I bring this up more just to keep us all up to date on the literature. It's a little hard to extend this paper to clinical practice, I think, but it does show some potential benefit for Bactrim prophylaxis in this patient group. So then getting to our next modifier, what are the adverse effects that a certain regimen might have? So what's the impact on the microbiome? What are potential drug reactions? And what is the impact on antimicrobial resistance? So clearly for our patient, azithromycin prolongs the QT interval. There's a risk for that, especially when using other QT prolonging medications. So for your adult patients who might be on cardiac medicines, and then for our patients who have other infections and are on fluoroquinolines, you can get pretty impressive, or on azoles, you can get pretty impressive QT prolonging with polypharmacy in this context. And then importantly, determining whether or not non-tuberculous mycobacteria are present prior to starting azithromycin prophylaxis is hugely important, especially in patients with bronchiectasis. You do not want to monotherapy or treat a patient with a non-tuberculous mycobacteria infection with monotherapy azithromycin. It creates a whole world of challenges for treatment and just not something that needs to happen. Importantly, even though that prior study that I mentioned showed that there wasn't much resistance difference between antimicrobial resistance difference between placebo and azithromycin treated patients. In another study from a while ago in otherwise healthy patients, you can see very rapid resistance induction to macrolides like azithromycin or clarithromycin with a short period of treatment. So this was a study of healthy volunteers who were randomized to placebo or azithromycin or clarithromycin treatment for a very short period of time. So the treatment period was only for about 7 days. And then following that, they did, or before and after that, they did oropharyngeal swabs to look for macrolide resistance and oropharyngeal streptococci. And you can see that shortly after treatment, that resistance rate increases significantly. And impressively, they follow these patients over a long period of time for 6 months. And you can see that the frequency decreases over time in the absence of macrolide treatment, given, again, that treatment was only for this first week and the increase appeared to persist as long as 6 weeks. It is something to be concerned with. Whoops, excuse me. And then finally, thinking about what's the impact of prophylaxis on the microbiota? And is there any impact on immune function or dysregulation in immune deficiency or immune dysregulatory patients from their prophylaxis? I bring these questions up just to show you that we don't know. We really don't know. There's very little to no data on this in immune deficiency disorder patients. And so it's not clear what impact the prophylaxis regimen choice has on the microbiota, and by extension, what that impact is from a change in microbiota on any immune deficiency phenotypes. To kind of illustrate the potential for impact of this, of microbiota ulcerations on immune deficiency phenotypes, I'll show a little bit of data from 2 papers. So these are in the context, these are 2 studies that were done a few years ago in stem cell transplant recipients, so not necessarily primary immune deficiency, just overall stem cell deficiency. And they show that broad spectrum antibiotic use, especially antibiotics that include anaerobic coverage, are independent risk factors for poor outcomes after allogeneic stem cell transplantation. So data from these studies showed, here you see probability of transplant-related mortality on the y-axis and time post-transplant on the x-axis. And you can see that in these 3 groups, you have patients who received systemic antibiotics before day 0, patients who received systemic antibiotics on or after day 0, and patients who patients who received no systemic antibiotics, patients who received antibiotics before day 0, and patients who received antibiotics on or after day 0. And so you can see that in the 2 groups of patients who received systemic antibiotics either prior to or shortly after transplant, there was significantly increased transplant-related mortality. Looking specifically at Gbhd and Gbhd-related mortality, this group looked at the use of very broad-spectrum antibiotics, so a carbapenem, which impacts anaerobic, which targets many things, including anaerobes, as well as zosyn, which provides anaerobic coverage. And you can see that Gbhd-related mortality was significantly increased in the group of patients who received these antibiotics compared to those who didn't. Now, this is not necessarily applicable to immune deficiency patients, but it does highlight one example of how broad-spectrum antibiotic use can impact patient care outcomes. And so I think is also illustrative of how more studies are needed to understand antimicrobial impact on immunologic phenotypes in immune deficiency patients. So getting back to our illustrative case, from his genotype-phenotype correlation There's clearly a risk, and from his history, there's clearly a risk of pyogenic infections, maybe, but maybe not non-tuberculous mycobacterial infection, and then also intact T cell and NK cell function. We're not pursuing a stem cell transplant for him for a variety of reasons. There is some evidence for azithromycin benefit in the context of bronchiectasis, as we reviewed. And we will avoid anaerobic coverage, so we'll not use clindamycin for Staph aureus, both to limit his C. diff risk, but also limit the impact on anaerobic organisms in his GI tract. And so for him, his regimen is Bactrim 3 times a week, amoxicillin daily, and azithromycin 3 times a week. So to conclude, prophylaxis is frequently used and needed to optimize the care of patients with primary immune deficiency and immune dysregulation. Evidence is limited, but can be extrapolated from other settings. Clearly, many factors impact the choice of prophylaxis, and it's hard to review all of them in 20 to 30 minutes. A one size does not fit all. We all know that in the context of immune deficiency. And there's really little knowledge of how antimicrobial and microbiota interactions might impact clinical course for immune deficiency patients. And as always, more studies are needed. So I really appreciate your time in coming to the conference today and in listening to my talk. I am here for questions in person in just a second via Zoom. Thank you all and have a good afternoon.
Hey, thank you very much, Dr. Dulick. Yeah, so if you have any questions, please feel free to add them in the chat. So I think that was a great presentation. All right.
I'm happy to cede some of my time if Lisa wants to expound on the question that came to her a little bit.
Oh, sure.
I actually have a question for you, if that's okay.
Yeah, of course.
A lot of times with like disorders like Nemo or even the stat disorders, we end up having to put patients on multiple different classes of antimicrobials and antifungal, antibiotic and things like that. How do you mitigate the risk of like prolonging a QT? Because a lot of these drugs that we have to use for prophylaxis have some really significant side effects, but they have to be used together. And so I'm always scared to do it up by myself, even though I've been doing it a while. So how do you, what's your approach to mitigating the side effects in these disorders that require things that, we know can do things like cause arrhythmias or liver damage and stuff like that?
I think we end up having a lot of patients on or some patients on the triple levofloxacin, fluconazole, and azithromycin combo, which is like the cardiologist nightmare.
Right.
I wish there were a clear way to go about it. I think it's kind of picking the least concerning thing to stop and crossing your fingers a little bit. I will say, and it's probably not the real indication for using this drug, there is a new azole that actually decreases your QTc, which is sort of interesting. It's isavuconazole, so it's sort of like the next generation posaconazole. I've not used it to, in that setting to actively decrease the QTc in any way, but it's kind of interesting, and it's crossed my mind a few times as we battled with that, but. It's obviously very different from fluconazole, so you're not gonna, you're not necessarily gonna need to prophylax against mucor in some of your patients. But in all honesty, all I have is, choosing the lesser of two or three, not evils, but what's the least risk in stopping in a way.
Sure.
We had another question come in through the chat. Can you comment about Candida prophylaxis in patients with STAT1 gain of function, for example, and whether antifungal prophylaxis is needed in patients on chronic antimicrobial prophylaxis?
Yeah, that's a good question. I think STAT1, yes. Again, Lisa is the STAT1 expert here, but in general, you're in all likelihood gonna battle with Candida. Clearly, there are as she talked about, there are a wide variety of phenotypes that you can see, and some patients will present with the CMC and some won't. But I think given the underlying predisposition and the relative low risk of fluconazole, it's in general indicated. I'll make it more of a conversational question answer session. I'm curious if, when you do ruxolitinib in your patients, Lisa, if you end up leaving them on a fluconazole in that setting or not.
Yeah, I do. And, that's a good question. So I do. And one of the reasons I think for everybody that Dr. Dulick asked me that was because fluconazole inhibits the clearance of ruxolitinib, so you can get upwards of almost massive amounts of levels of ruxolitinib, and we have no way to measure toxicity in that regard. So, but there is a dosing chart in the ruxolitinib package insert, and so I use that as a guide for using fluconazole, and then posaconazole doesn't, in general, is not as potent an inhibitor as ITRA or fluconazole is. So ITRA is the most potent inhibitor of the P450 that it is cleared through, and then it kind of goes down from there. So posaconazole is not as strong an inhibitor. I mean, it is. And then the newer generations of JAK inhibitors don't tend to have as much of an interaction with the azoles. So, for example, there's a JAK inhibitor in clinical trials named itacitinib for Gbhd prophylaxis, and that one doesn't seem to have as much toxicity when paired with an azole as ruxolitinib does. And so I leave them on fluconazole. I try to dose it based on the package insert, and then and then if I have to have them on higher doses of the azole to control the CMC, I just do frequent CBCs and liver panels to see if I see any lymphopenia, neutropenia, thrombocytopenia, or conversely, some liver enzyme elevations. So that's kind of how I handle it. But I have very nicely treated with high doses of Rexo and Vori and Posa together under just close supervision, because I also feel that the ruxolitinib actually mitigates the severity of the CMC. So in some patients who have either resistant candida or just had so much candida burden before they were started on a JAK inhibitor, it tends to flare when they get a cold or they have an inflammation for some other reason. And they're a little harder to treat, but I do think that the JAK inhibition actually mitigates the burden of CMC. So I try to get them to be treated together. So we just kind of do it that way. I'm hoping that the newer generation of JAK inhibitors are a little bit easier to use. And actually for the clinical trial that I mentioned, we chose itacitinib because of the preclinical data and some of the pharmacokinetics related to the azole interactions.
Great. Let's see. If anyone has any other questions, you can enter them. Give a minute. I know we're a little over time, so. Oh, sorry, Dr. Brooks. Okay. All right. Well, I think this is it for today's session. Thank you both to our speakers, and thank you everyone for attending today. And we hope you enjoyed today's session. I'll be sending out an evaluation next week to all of our attendees, so look in your emails for that. But if you need anything, you know where to find us. Thank you very much and have a good weekend.